Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, my incredible and knowledgeable nurse practitioner, Rosalind Arp, and I share our combined 30 years experience to guide both men and women as they age. Listen as we dive into a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. These real-life insights are always rooted in solid scientific knowledge. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Hi, everyone. Today we're talking about a really common surgery, hysterectomy, and its effects on sexual function. Hysterectomies are actually, for women, the second most common surgery performed in the United States, the first most common being a C-section, but we're still talking about tons of women who at some point during their life are going to have a need for a hysterectomy.
So most women will get a hysterectomy because of pain, fibroids, heavy bleeding, endometriosis, or even sometimes cancer. And a lot of the times this will solve the issue that they're having. However, a lot of women are also concerned that it can cause another issue, especially affecting their sexual health.
For most women having hysterectomy, they really don't notice any change to sexual function. Most of the orgasm comes from the clitoris, and having a hysterectomy really should not disrupt any of the blood flow or nerves to the clitoris. But there are sometimes some other changes that can affect women's sexual health negatively, and it at least deserves a conversation with your doctor before you have a surgery. But let's start with what actually is a hysterectomy. The original meaning of hysterectomy comes from a Latin word, hyster, which actually it comes from hysteria. So many years ago, when women would have hormonal problems at perimenopause, they would be anxious, nervous, heart palpitations. All the male doctors at the time thought they were going crazy, and they called that hysteria, and they thought the solution for it was taking out the uterus, kind of the source of womanhood. And that's how we got our word for hysterectomy.
That's very interesting. But I was going to say, most of the time when we actually talk to patients, they say they have a complete hysterectomy, thinking that their ovaries are included with that. Can you talk more, Dr. Jackson, about the different types of hysterectomy and how it's done?
Yes, this is a big area of confusion for women because what women call a full or a partial hysterectomy is not what the medical term for a full hysterectomy is. So let's go through all the parts that are related to the uterus and what can be removed. So when we're talking about the uterus itself, the uterus actually has two parts: the body of the uterus, which is called the fundus, and the opening of the uterus, which is called the cervix. And for most women, when they're talking about a hysterectomy, it's removing the uterus and cervix. From a medical standpoint, that is a hysterectomy. That is a complete hysterectomy. The uterus and cervix is a complete hysterectomy. If we add removing the fallopian tubes and ovaries to that, that is actually called a hysterectomy and a bilateral salpingo-oophorectomy, which is a long and complicated name, but a lot of women misunderstand and think a complete hysterectomy means removing the uterus and ovaries, whereas a partial hysterectomy means only removing the uterus. Have you had patients get confused on this?
Yes, a lot. And usually I would have to ask them, do you still have your cervix? And a lot of times they're like, I don't know, is the answer. Or sometimes they'll say, I had a complete hysterectomy because they removed my ovaries as well. But by the way, that's one of my favorite words in medicine is oophorectomy.
So you're proud that you can actually have that roll off your tongue.
Yes. Because, I struggle with certain words.
The easiest way, if you're not sure to know what parts were removed, is really just to talk to your doctor and have an exam. It's pretty straightforward to do a speculum exam and see if the cervix has been removed. And we can do a bimanual exam, which is a vaginal exam, to see if the fundus of the uterus has been removed. Sometimes it's actually hard for us to tell on exam if the ovaries are removed or not. Normally in menopause, the ovaries start to shrink and they get very small. They can shrink down to about the size of an almond. So if we can't feel them on your exam, that's a normal thing. If we really need to know if your ovaries are present or not, we might need some form of imaging like an ultrasound or a CAT scan.
And sometimes even in the ultrasound, it's harder to see if the bowels are in the way.
So it is important to know as a patient whether you still have a cervix or not.
Yes, because this determines if you still need a pap smear or not, because a pap looks for cervical cancer, and people who've had a partial hysterectomy should be getting their cervical screening still on a regular basis. So I know, Dr. Jackson, I've seen you do multiple types of hysterectomies. What are the different routes that you can do a hysterectomy in?
If you need your uterus removed, there are three main ways we can get it out of the body. The traditional way is an abdominal hysterectomy. So that's making an incision through the belly and removing whatever parts we're going to remove, the uterus and or the ovaries. That's the most invasive way. That incision on the abdomen causes the most pain. It gives you the longest recovery. But from a surgical standpoint, it gives us access to the entire abdomen. So if your uterus is extremely large from fibroids or cancer, this might be your only option. The safest way to have the uterus removed is with a vaginal hysterectomy. This is actually my favorite way to do a hysterectomy if I'm able. It means the uterus comes out through the vagina, so no incisions on the abdomen. This type of hysterectomy gives you the least amount of postoperative pain, the quickest recovery, and it's actually associated with the lowest side effects, the lowest risks associated with the surgery. Unfortunately, if your uterus, again, is too large or bulky, it may be too large to come out through the vagina. And there are very few patients where I'll just examine their vagina and the vagina is just too narrow to work in and to operate in. The final way we can remove the uterus is a laparoscopic hysterectomy. And this is where we put a little camera in through the belly button and usually a few more tiny incisions in the belly to put instruments in. Each of those incisions is just about 1 to 2 centimeters. We can disconnect the uterus. It actually does come out through the vagina, but then it's repaired laparoscopically. And the most advanced way now is actually to do a robotic hysterectomy. This really is a laparoscopic hysterectomy, but instead of the surgeon working the instrument with their human hands, we attach robotic arms to the instruments, and the surgeon works the instruments with the robotic arms. And from a surgeon standpoint, it gives us a lot more mobility and dexterity and better view of the abdomen inside, so we can do a lot more detailed work.
That was one of the best surgeries I've seen that you've performed, was the robotic hysterectomy.
Robotic hysterectomies are really neat. And you want to make sure if you are a candidate for one that your surgeon is skilled in doing that. But it's great. You can watch some YouTube videos on them. Just watching the robotic arms move, it does seem very futuristic. But just remember, there's a surgeon right on the other end of those robotic arms. It's not just, your Roomba going in to do your surgery.
That's funny. I was going to go back to the partial hysterectomy. Why would the surgeon leave the cervix behind?
There are a couple of reasons, but we used to think that if we just took the body of the uterus or the fundus out, but left the cervix behind, that we would be reducing that woman's risk of getting pelvic organ prolapse in the future. That's where the walls of the vagina fall down or the bladder starts to fall down and protrude out through the vaginal opening. We used to think hysterectomy was a big risk factor for this, and leaving the cervix in would prevent it. So supracervical hysterectomies, which is just removing the top part, were done for many years. But then we realized it didn't really have as much of a protective effect as we wanted. And as you mentioned before, if you do a supracervical hysterectomy, that woman continues to need to get her pap smears. She can still get disease in the cervix, and she might even need a second surgery to go back and remove the cervix if something happens to it. So now I think most surgeons try to remove the cervix at the time of hysterectomy as long as it is feasible to do so.
Is there any advantages of leaving the cervix in terms of your sexual health?
So from a surgical standpoint, yes, it does make the surgery a little speedier if you leave the cervix in, because there's a little less dissection that you have to do around the cervix. Since most surgeons are trained to remove the cervix with hysterectomy anyway, I don't think that's a big defining point there. What it really comes down to, which is the point of our podcast today, is does it have any negative effect to your sexual function? For most women, the answer is no, because the cervix itself is not a major contributor to sexual satisfaction or orgasm. But for some women, they can actually have very specifically a cervical orgasm. All women can reach orgasm with clitoral stimulation. That's a given. As long as we have direct clitoral stimulation, women should be able to reach orgasm. But some women can also reach orgasm with cervical stimulation. So that would have to be deep penetration. It's actually carried through different nerves. The cervical nerves connect to the brain through the vagus nerve and they don't travel through the spinal cord. What's interesting about that is it means that even women who are paraplegic, they have a spinal cord injury, they may no longer get any clitoral stimulation because the nerves are trying to travel up the spinal cord and then they reach that injured area, but they may still have cervical orgasms because the cervical stimulation travels up the vagus nerve and does not travel up the spinal cord.
So how about removing the uterus, Dr. Jackson? Does that affect your sexual function?
So the uterus itself does not produce any hormones. So when we remove it, you're not going to notice any fall in hormones. And if we're just talking about the fundus, the body of the uterus, women really shouldn't feel any difference with sexual function after hysterectomy. In fact, most women find that sex is significantly improved after hysterectomy because the reason they needed the hysterectomy in the first place has been resolved. She's no longer having heavy flooding bleeding. She's no longer having pelvic pain. She's no longer having fibroids that are, bloating her out. So most women, once they've healed, actually feel much better having intercourse with their uterus removed.
Yes, I've also heard from patients that after their hysterectomy, the deep penetration pain that they would get from being hit with the penis on their uterus would actually go away.
Right. We expect during intercourse that the penis pushes on the cervix and kind of rocks the uterus back and forth. And as long as all their anatomy internally is normal, that should feel pleasurable. But if their internal anatomy is abnormal from fibroids or endometriosis, pushing that uterus back and forth is just pulling and tugging on scar tissue or big tumors in there. And that obviously does not feel comfortable. And many women kind of figure it out on their own. If they're trying to have sex and it hurts with deep intercourse, they'll just change positions or amend how they're doing it so that he's not able to get as deeply inside and not stimulate that pain.
So how about when you remove the tubes or the ovaries? Does that affect anything in terms of sexual function?
So let's look at those each separately. The fallopian tubes are first. So these are the fallopian tubes that carry the egg from the ovary into the uterus. And they also do not produce any hormones. So removing the fallopian tubes is not going to have a negative hormone effect. And if we just remove the fallopian tubes alone, they have no effect on sexual function. There's been a recent change in thinking. We used to think the fallopian tubes were pretty benign. Leave them in, take them out. It didn't really matter. They didn't have any effect on women. But now we realize that many advanced ovarian cancers, the ones that you hear about where they're all over the belly and they didn't give the woman any early signs, they probably started as fallopian tube cancers. So if a woman needs a hysterectomy for bleeding or fibroids, it's now recommended that we remove her fallopian tubes at that time, because by doing so, we can reduce her ovarian cancer risk, even if we leave her ovaries in. So it's the benefit of reducing ovarian cancer risk, but not affecting her sexual function and not affecting her hormonal function.
And usually now you recommend this self-injectomy, which is the removal of the tubes rather than doing their tubes tied.
Right. If patients want a tubal ligation or a sterilization, in the past, we would do a stitch around the tubes or sometimes just remove a small section of the tube so the egg couldn't pass through. But now it might be the better part of valor to actually remove the tubes entirely. It doesn't take that much longer at surgery. It gives them the sterilization that they're looking for, but it also gives them the benefit of reducing their risk of ovarian cancer. And that's really so important because we don't have any other good tests to look for ovarian cancer at its early stages. For cervical cancer, we have the pap smear. We can get our pap smear according to guidelines and make sure that any early changes are caught. For breast cancer, we have the mammogram. We can look for early masses and remove them before they become a problem. But we don't have that kind of good screening test for ovarian cancer as of yet.
Mm-hmm. Well, how about the ovaries themselves? Like, how does that affect sexual function?
So the ovaries are certainly the source of most of women's hormones, estrogen, progesterone, and testosterone. So removing one or both of the ovaries definitely is going to have a negative hormonal function. It may not necessarily change the active intercourse in and of itself, but loss of that estrogen and testosterone can really affect a woman's arousal and desire. It can affect the ability to have good blood flow to the genital region and clitoris, which of course is important for orgasm. So Making the decision to have a hysterectomy, uterus alone, might be fairly straightforward, but making the decision to add removal of the ovaries to that surgery definitely deserves a big discussion on, do the ovaries need to be removed? And if they do need to be removed, how are we going to replace those hormones that we know we are just turning off, like turning off a faucet?
So I know there is a different type of hysterectomy for mostly for cervical cancer patients called the radical hysterectomy. Can you tell us more about that?
All the hysterectomies we've been talking about, whether they're done vaginally, abdominally, or laparoscopically, we've been talking about simple hysterectomies in medical terms. Simple meaning we only want to remove the organ we're talking about. But when a patient has cancer, we don't want to just remove the organ. We want to remove the organ and some of the normal tissue around it. And that's to make sure we don't leave any cancer cells behind. So in women who have cervical cancer, they may get something called a radical hysterectomy, and that's removing the uterus and cervix with a lot of the tissue that surrounds it. And some of the tissue that happens to surround the cervix is the vagina. So many women, after having a radical hysterectomy, end up with a shorter than normal vagina. Now, this definitely can affect sexual function because they may feel like their partner doesn't totally fit inside. Because they're losing their cervix, they're losing the ability to have a cervical orgasm if they were able to achieve that beforehand. And sometimes they can experience pain. There might be some scar tissue at the top of the vagina. And as the penis tries to rock the top of the vagina back and forth, if it's tugging on that scar tissue, that can lead to pain. Obviously, if you have cervical cancer, you need to treat that. We want to save your life, but we do also want to think about the quality of that life afterwards.
I know that there are devices out there that can help with that, that men can wear at the base of the penis to help them not insert their penis all the way in the middle of intercourse if the woman has a shorter vagina. I think it's called ONUT. OHNUT.
Such a great name. Yes, exactly. And even though all men would like to think, oh, sure, I definitely need that. What we usually would recommend if you have had a simple hysterectomy or a radical hysterectomy, once you're cleared for sexual activity, try it first and see what happens. And, you can kind of figure out by trial and error, hey, I can get partway in. And then if I try to push harder, it causes her pain. Then doing that, using that ring that prevents full penetration may be a good way for both partners to still get a satisfying sexual experience.
And some of the female patients I've had in the past have been worried about how their partner is going to feel them during intercourse after their hysterectomy. But most men actually they don't feel any difference because the penis is only going in the vagina. So unless you've had a radical hysterectomy, most men don't feel a change during sexual intercourse.
Exactly. Unlike the tip of our finger that's very sensitive and can tell very specific sensations, the tip of the penis is not that sensitive. So as long as it has a vagina to go into, it's usually pretty happy. So it doesn't notice if the woman has lost the cervix. Your male partner is not going to feel any difference if you have a hysterectomy versus don't, or if you have a cervix versus you don't.
So do women need to get a pelvic exam after they've had a hysterectomy?
That is such a great question because so many women either reach a certain age or have had a hysterectomy and reach a certain age and will hear from a physician, oh, you no longer need your GYN exam because you don't have any parts down there. And of course, I just hate that answer because you still have a vagina, you still have vulva, you still have a clitoris, you can still get pelvic organ prolapse, you can still get cancer in your vagina and your vulva, and you can still get a bunch of non-cancerous conditions of the vagina that happen as we age. So as gynecologists, we definitely recommend that women continue their vaginal exam once a year by a qualified provider. You may not recognize it because your gynecologist is so proficient, but when we do your exam, we're actually checking the lips around the opening of the vagina, the introitus, which is right around the opening, the walls of the vagina itself. We're looking to make sure nothing's dropping down or falling. Of course, we're doing your vaginal exam and collecting your pap smear if necessary, if you still have your cervix. But I would definitely challenge any physician who said, oh, she's too old, she doesn't need her exam anymore, or she's had a hysterectomy, she doesn't have any parts. It is very important to continue to get your vaginal exam on a yearly basis.
Yes, I agree with you on that one because I actually had a very interesting case, a patient who was, I believe she was in her 70s and came in and asked me, do you really need to get this done? Do you need to get checked? I've had a hysterectomy and most of my friends don't see a gynecologist anymore. And I told her, as long as you have a vagina and a vulva, you should still get checked. Unless somebody else is checking it, I do recommend you coming in to get it checked. And as I said that, and we talked about other things, and as I started her exam, I saw precancerous cells on her vulva and had to send her to GYN oncology right after.
And those are things that the woman herself may have had no symptoms from. She had no irritation, no bleeding, no itching, but a qualified eye can find that. And as long as we find it early, it usually is a non-issue. It's a small area that might be monitored or removed, and then it's cured. But we would hate for that to progress because someone was told they no longer need exams.
It was validating at that point.
It made you feel good as a provider to.
Yes, because I'm like, okay, this is the reason why we always have to do it.
Exactly. And I can't tell you how many times I've done an exam where I will ask the woman if she has any concerns or problems. And she said, no, but I was told to come in for my exam, and I find some early prolapse or I find some atrophy. And I'll say, do you have any dryness or irritation? Oh, well, yeah, I have that. How about bladder urgency? Are you rushing to the bathroom? Sometimes you can't make it. Oh, well, yeah, I have that. So they came in saying they had no concerns. But then when I actually ask them more, I'll say, you have a little prolapse. You have some of this thinning and aging of the tissue, but we can correct all of those things and improve your quality of life. So even if there's not a precancerous reason, we still want women to feel great and feel their best quality of life.
Yes, I always hear the normal part of aging. I'm like, no, it's not normal.
Yes. How many times a day do we have to tell people just because it's common doesn't mean it's normal? So making sure that you stay on top of those, because it's always easier to fix a problem at the beginning stages rather than when it's well developed. So if you are a woman who is considering or needing a hysterectomy, of course, you should have a pre-surgical conversation with your surgeon, and you want to know why you need the hysterectomy and what the risks are for it and what the recovery should be. So what things would you like to know as a provider from your patient when they say, I've had a hysterectomy?
So really, what part was removed? Why was it done? Because knowing exactly what was the reasoning behind it, and what treatments did they have afterwards? Especially if they've had their ovaries removed, did they start hormone replacement therapy? Did they start them a vaginal estrogen cream? And any other complications or side effects they might have had after the hysterectomy?
And I think as a patient, sometimes when your doctor tells you need a hysterectomy, you're having heavy bleeding, you've tried many things, they haven't worked. They may be so overwhelmed with just the thought of needing a surgery and needing a hysterectomy that they don't think to ask these additional questions. And for most women, you're going to have the hysterectomy, you're going to recover fine. The problem that you originally had is now gone, but now you have to live the rest of your life. So you don't want to think about after the fact, boy, I wish my ovaries had not been removed, or I wish we had done the surgery in a different route. Why did I have to get a big cut on my abdomen? Was there an opportunity for me to have a vaginal hysterectomy? I could have been back on my feet much more quickly. So knowing that these things exist and knowing to ask your surgeon, I understand we need to do the hysterectomy because I'm bleeding heavily, but what about my sex life afterwards? Is it going to change? What about my hormones afterwards? Those are all very valid questions. It's really rare to have to do a life-saving emergency hysterectomy. So you should be able to take the time to talk to your surgeon about those questions.
I agree.
And
Having open communication with your surgeon is very important, especially for something as drastic as a hysterectomy, because it is removing an organ.
Exactly. I'm always telling patients, even though I love talking to my patients and educating them, every now and then I get a patient where I just feel like we don't click as a relationship. She's somewhat mistrustful of me, or she's just not happy with what I'm telling her. And I am not offended by that at all. I encourage those patients to say, you know what? Go get a second opinion. Find another surgeon. There are plenty of great gynecologists out there. You want to find someone who not only has good surgical skill, but that you really feel confident in. So if something is just, you're feeling like, boy, I just don't feel like my questions get answered, or my surgeon's not listening to what I'm asking them, I really encourage you to find someone who does, because you need both parts, the good surgical hands, but also the good relationship with your physician. And then, unfortunately, even though hysterectomy does solve a lot of problems, for some women, it is not the only solution. It may be one step, but then they still can go on potentially and have some other problems. I would say pelvic pain is probably the most common diagnosis for that. So many times when women have pelvic pain and we've taken them through an evaluation and we've tried all other things, sometimes we say, we're not quite sure what's going on, but let's try to do a hysterectomy. Hysterectomy does solve pelvic pain about 80% of the time, but that still leaves 20% of women who say, I had my uterus out and I still have pain and I still have difficulty with intercourse or other problems with that. So just also recognizing that it may not be the final step in your journey. For many women, it is, but there are some other things that they can move on to if hysterectomy does not solve the problem, or if they still have sexual issues after hysterectomy.
And a lot of the times too, the type of pain they were having prior to surgery might go away, but they might have new type of pain afterwards. And usually it's because of the scar tissues.
Right. And scar tissue typically doesn't form immediately after hysterectomy. It takes some time to occur. Patients may feel okay initially after hysterectomy, but then several years later, they have sort of this slow onset of deep pain with intercourse. And that may be some scar tissue setting in at that point.
And then also the scar tissue, it's kind of there's also surgery that where you remove the scar tissue after the hysterectomy, or if they do form the scar tissue. And that's kind of a double-edged sword from what I understand, because once you remove the scar tissue, you can create new scar tissue from the surgery you had from removing the scar tissue.
Exactly. Scar tissue is one of those challenges. We can't test reliably for it. A CT, an ultrasound, an MRI, it doesn't light up on those tests. It really is your surgeon saying, hey, you had a hysterectomy, you were fine for many years, now you have this new onset pain, and I've checked for all other things, and I really think it's some scar tissue. So it really is your surgeon's best guess. In order to release scar tissue and get you some pain relief, we want to do the most minimally invasive surgery so that we are able to remove scar tissue with the smallest chance of creating scar tissue with the next surgery. And so often the best way to do that is laparoscopically with that little camera through the belly button. It lets us be a little more precise and create less tissue damage while we're performing the surgery.
Is there other complications that can occur post-hysterectomy?
Absolutely. Just like I was saying, if you did well with your hysterectomy, but then sometime later you start to develop pain, it's not automatically scar tissue. You need a good exam, because a lot of times we will also see that the muscles of the pelvic floor can go into spasm after surgery. So the muscles of the pelvic floor are like a shelf that stretch from side to side and front to back. I always tell patients when they're working properly, it's like a nice snug pair of underwear pulled up underneath your skin, holding everything in place. But if they are pulled up too tight, they can cause pain in the bladder, pain in the vagina, and even pain in the rectum. So a good pelvic exam should be able to identify that. When those muscles are really in spasm and they can't release, one of the main complaints is that sex is painful. But patients can also have painful urination or urgency and frequency. They have to go all the time. They can even have rectal spasms, where they will describe it just as a sort of a red hot pain that goes right up the rectum randomly, that just grabs them throughout the day. Pelvic floor spasm can occur immediately after hysterectomy, or it can occur distant from hysterectomy. So we really need to keep that in our mind as a possible cause of pain after hysterectomy.
Yeah, so I think the main point is, if you, after hysterectomy, really, if you're having any sort of pain or any issues sexually, being assessed for that, trying to pinpoint specifically where it's coming from, will help us decide what treatment options is best for you.
And then the final point I would say to discuss with your surgeon, if you think this would affect you, is that for many women, they feel that their uterus is sort of the source of their femininity. And without a uterus, they're no longer a woman. Obviously, I don't believe this to be true, but if you feel like you really don't want to have a hysterectomy because will I be feminine after that? Will I still be a woman? And you may also think that if your ovaries are removed as well, that's a very real concern. And you should talk to your surgeon about that. From the ovary standpoint, very often there are reasons we can say, hey, it's not mandatory to have the ovaries out. We can leave those behind. If losing your uterus is a big psychological concern for you, you might be able to talk about other treatments that are non-surgical that still get you to the solution you want, that still solve your bleeding or solve your pain. So that is something to think about if you feel that it would affect you after a hysterectomy.
So today we talked about hysterectomy has a positive effect or no effect in our sexual function, but it's important for us to discuss about the possibilities or complications that can occur and what you need to be talking to your surgeon about if you are considering a hysterectomy and how it's going to affect your sexual health.
Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.